Hiya, this is Emily and Gemma.
Hi.
We are today just going to talk about neonatal abdominal X-rays, and this is session number 2. So we're looking at free air. In our first kind of abdominal X-ray one, if you haven't looked at that session, then go back to that. That should be one of the earlier videos. And this is we're just going to have a little overview of what we learned in that session. So we were looking at the bowel gas pattern, how far along the GI tract had the air gone, what was the distribution of the bowel loops, and then what was the calibre of the bowel loops. So yeah, if you haven't done that, go and look at it and then come back to this one. So we're just going to move on with this. So this time we're looking at free air. That is also called Pneumoperitoneum. We're going to look at Pneumatosis intestinalis, portal venous gas, and then also just a little look at UAC and UVC positions. So what do we mean by free air? And then what is the most likely reason for free air? Gemma.
Okay, so free air is basically any air that we see on X-ray that we don't expect to see. So air in a position that we wouldn't normally expect to see it. And it's most commonly caused by the things that we're going to cover today and things like perforation.
Great. So yeah, as Gemma said, some of the causes of free air are perforation. So you can get perforation within the gastrointestinal tract or within the respiratory tract. So it's kind of air that has gone from one of these places into an area of the abdominal kind of area that it isn't meant to be. So it can also be caused by medical treatment, such as the placement of UVCs or UACs, and then one of the most common causes of free air is NEC, so necrotizing enterocolitis, or kind of infection within the abdominal cavity. So NEC is an acute abdo condition for neonates, and there's multiple factors, but the reason why it kind of shows up within an X-ray is because there's damage to the intestines, and then there's necrosis within the bowel. So this is why you may get some air in places where it shouldn't be, and it can just look slightly abnormal. So some of the things that we're going to look at, so these are the signs of free air on an abdominal X-ray, and this is what you may hear people refer to it as. So there's a football sign, lucency over the liver, air under the diaphragm, and the Wriggler's sign. We're going to cover each of these today and just show you some examples. So the football sign. So when we're talking about the football sign, imagine an American football, and this is where the abdominal cavity is outlined by gas. So looking at this, as you can see, there's it's quite a sharp line around the whole abdominal cavity, so it looks a bit like an American football or kind of a rugby shape ball. Also where the arrows point into, this is the falciform ligament, so usually it would not show up on an X-ray. However, because there's air in the wrong places, you will get this this kind of white line going straight down, and that's just the falciform ligament that is showing up. So should kind of look similar to this. So we'll just look at another one. And again, this is a little bit harder to see, but you can kind of see the rugby ball shape, and then the falciform ligament also is present there. And this one is another one which is a bit of a nasty one. So there's free air, which is apparent, and you can see that kind of big ball shape, and then there's the falciform ligament, which is pretty obvious there as well. So that is the football sign.
Okay, lucency over the liver is another sign of pneumoperitoneum. So again, think back to X-rays that you've seen before. Normally we expect the liver to look quite dense and quite white, and it sits to the right just below the diaphragm, or when you're looking at the X-ray it's on the left, but that's obviously the baby's right. So let's look at what it would look like if we're seeing some lucency over it. So here you can see that rather than the liver shadow looking white and flat and dense, there's some areas of increased lucency. So there's some black gas projected over the liver. So that is lucency over the liver, and that is an abnormal sign. Then we've got air under the diaphragm. So again, another sign of pneumoperitoneum, another abnormal finding. Again, think back to X-rays that you've looked at. You have your lung fields, they come down, meet your diaphragm, and directly below the diaphragm, particularly on the right, is your liver shadow. So if you're seeing air under the diaphragm, this is what you might expect to see. So the arrow is pointing to the area that we're talking about. So you've got the white of your liver shadow. Then you've got this sort of track, and then there's another white thin line above it. So that thin white line is the diaphragm, and then the track in between is some air under the diaphragm, above the liver. Again, another abnormal finding.
Okay, so if people refer to the Wriggler's sign, so this is when there is air on either side of the bowel wall. It also might be called the double wall sign. So it's kind of where gas is outlining both sides of the bowel wall. So it may appear like this white line. So you will see kind of in the earlier abdominal presentation, you'll see that we can see shapes of the bowel at times. However, this is a thicker white line. So it's where there is gas where it shouldn't be, and it's portrayed like this. So also in this one, you can see that kind of thicker white line in different areas, and this is kind of an abnormal finding, and yeah, might be referred to as the Wriggler sign. So again, it's free air where it shouldn't be.
Okay, so pneumatosis intestinalis is basically when you have got gas within the bowel wall. And the best way to think about it is to think about a train track, and that's what the bowel wall looks like. So normally on an X-ray, the bowel walls are white and they're fairly crisp, thin lines. Emily's already talked about them being like thickened with air. But when we're talking about pneumatosis intestinalis specifically, then this is the sort of picture you'll get. You might want to zoom in on this if you can. And what you see like it's almost like a double wall. So you've got the white line of the wall, and then there's a space and then another line. And then if you looked up closely, what you might see is like little pockets of air, and that's what makes it look like a train track. So this X-ray shows it a little bit better. Again, you can see the wall is thickened, and that there's air in the bowel wall, and it's quite widespread on this X-ray.
Lovely. So portal venous gas. This is when there is air within the biliary tree. So it can be a sign of NEC. However, in the absence of NEC, so obviously looking at the whole clinical picture of the baby, it could be kind of gas from a UVC insertion. So like Gemma was saying before, the liver should be kind of white and all one colour. In this picture, again, you might need to zoom in a little bit. It's not kind of crisp white. You can see a bit of shadowing over the top, similar to kind of branches of a tree. So as we were saying, it could be caused by UVC insertion. This is why we kind of have to flush both UVC ports to try and make sure that we don't get any air in that. Okay, so it can also be seen in this slide. And again, the liver's not shown as complete white. There is kind of the branching of the trees off there. You may hear a little bit of rain going on. It's a bit of a noise which is distracting us slightly, but we'll continue. Okay, so now we're going to look at UVCs and UACs and just kind of their placement and what you would see within an abdominal X-ray. So UVCs, we use them for central access for fluids and medication. These are really good for our preterm babies, especially who won't be feeding for a little while. So it just means that we can give them fluid, and that's quite a good secure line to have in place. So it passes through the umbilicus to the umbilical vein, the ductus venosus, and hepatic vein, and then into the inferior vena cava. So the position that you'll see on the X-ray, so you'll see it pass in and up on a straight line. So it should be kind of midline and to the right of the spine. However, when you're looking at the X-ray, it's to the left, but obviously we're thinking about the baby, and on them it will be to the right. So the final position should just be below the diaphragm in that straight line, and that's kind of seen as quite a good position. So you can see on this X-ray that the UVC is in a nice kind of straight line in the midline. It goes up to the diaphragm, and that, from what we can see, appears to be quite good. What we do not want is this. So we don't want the UVC to angle sharply to the left or the right. And if we did see this, it would either need to be pulled back or it would need to be kind of repositioned completely and removed.
Okay, so UAC positions. Again, we use our UACs for central access, to monitor blood pressure, and for blood sampling. So again, these are really handy in our really tiny babies, save us having to prick them for bloods all the time. So think about your fetal circulation, and if you can imagine that in your head, then you can visualize where your UAC should be going. So it passes through the umbilical cord in one of the umbilical arteries, and then rather than heading upwards like the UVC does, it goes down. So it travels down through the umbilical artery where it joins the internal iliac vessels, which feed into the aorta, and then it should travel up the descending aorta. So on an X-ray, what you're looking for is that initial downward travelling, and then it should follow up to the left-hand side of the midline. So again, when you're looking at the X-ray, that's going to be the right, but it's the baby's left. And you're looking for the final position to be between T6 to 10. So I'll explain that a bit more now. So you've got your, this baby's got two umbilical lines. You can see the UVC and a UAC. So the UAC comes in, it looks like it loops round, but remember that part of this line is what you can see outside of the baby before it goes in. But the UAC goes in, it dips down, as we said it should, and then it starts to head upwards, and it is towards the baby's left, and we're looking for that final position. So we said T6 to 10. So when we're talking about that, we're talking about the thoracic vertebra. And those are the vertebrae that our ribs are attached to. So there are 12 of them. And the way to count them is to count down from the ribs at the top. So find the first rib and count all the way down. We assume that most people have 12 ribs, but we can't take that for like certain, so we should check. So count down, find number 12, and then the 12th and the 11th rib attach directly to their corresponding vertebrae, whereas the others sort of float between. So that's where we count down first. So count down, find your 12th rib, track it into the vertebrae it's attached to, and then count backwards from there. So 12, 11, 10, 9, 8, 7, 6, and then we can see that the tip of this UAC is actually just above T6, so it's probably in a little bit far and would like to come back. And obviously we could actually use echo and things to help confirm that as well. So here's another X-ray. So again, we're looking to check the position. So our UAC comes in, it heads down before it comes back up. It is towards the baby's left, and we're counting down those vertebrae. So we can see the 12th rib, or what we assume to be the 12th rib on this X-ray, attaches to a vertebrae. So we say 12, 11, 10. So the tip of this UAC looks to be sitting at around T10, so sort of the lower margin that we would be comfortable with it at.
Lovely. So yeah, we've just given you a little overview, which might be able to help you just with looking at some of these abdominal X-rays and when kind of when free air has been mentioned. So yeah, just giving you a little bit of pointers for that. If you want to kind of discuss things any further, or just ask us any questions, then speak to any of the ANMP team, see us on the unit, or drop us an email. Thank you very much.
Thanks for watching.